Good morning. Wow. I forgot what day it is. I almost did it again. Happy Thursday, everybody. It's a delight to see you here. I I think it goes to show how pathologically connected I am with VMR that I'm on the inpatient wards, which means that my usual work is during the morning. And so I haven't been able to join as much. And even though I haven't really missed a session, I feel like I've been far away. So it's nice to see you all. Um, Today is an all eternal affair with uh, a case from our beloved Anmol. And all that you need to know from me about Anmol is she shows up early and apologizes for being late. And I think that's my introduction for Anmol. We're very, very excited for you, but it speaks to the volumes of your character. Um, and I will tell you that I think even if you showed up now, it still wouldn't be late. Um, I am thrilled though to discuss Anmol's case with Hui Ting, who I am her and I have chatted a lot about the sadness that I think we all feel that we don't get to see her live as much in VMR, in large part, actually in complete part due to all the other work-related obligations she has. But I think of all the people that are probably here, she is so deeply entrenched and involved in almost everything behind the scenes. So I know a lot of you appreciate the notion of what it takes to keep all of the stuff that we do going and online. And many of it you probably don't see rising at the surface. And only when you're part of the team do you see just the sheer mountain of effort it takes to keep everything alive. And wherever you look within CP solvers, you'll probably see her name, either in research or in infographics or maintaining the weekly VMR schedule. And of course, when the subspecialty team is looking for somebody to help them, not the least bit surprised to see you added to the group within a few hours, we think. So we're so grateful for all the things you do. And as is customary, we like to celebrate that by making you sweat a little bit. So, welcome to VMR. We're very, very excited to share the stage with you and discuss this case. How are you feeling?
Hi everyone. Oh my God, thank you so much for your word. Oh my God, it's made me like, I don't know, I'm tearing a little bit. Get me so emotional because this is like the family that I always wanted. And I respect all of you. You guys are amazing. And as you said, I haven't been able to join as many live session as I want to, but it has become a ritual for me every morning when I drive to work. I play the last episode of VMR and I try to learn as much as I can when I'm driving. So, I mean, I know that I haven't been in a live session, but at the same time, I still feel connected to the group. And as you said, there's a lot of things going on behind the scenes that not everybody know about it. We have the case review committee, we have infographic, we have emails, podcasts, and I'm so grateful for everybody's help because it's like a big team working behind the scenes. And speaking of the team, like Amo, I mean, she's one of the most recent member, but she's driving so fast. And I'm so glad to see that. Even though I'm not a live session, but I see everybody working so hard. So she's also like really nice representation of the team. So yeah.
Very well said, Wu. And the only sneak preview we have is Anmol asked us to make her a co-host. So we know there's a picture coming, hypothetically. So we'll pass the mic to you, Anmol, to say hello, and then we'll jump right into the case.
Okay, so a very good morning, good afternoon, and good evening to everyone. And I am really honored hearing so many beautiful words from everyone. It's actually coming from my heart that I am really honored to hear so many beautiful words. And for the introduction, I am an international medical graduate from Punjab, India, and this is my fifth case presentation, I think. And I really hope that I lose count soon. That is the goal. And yeah, and also Hui Ting and I share our birthdays. So that was one of the reason I chose today as my case presentation day. And yeah, I'm excited for today as well. Hopefully I make your 1 hour worth it.
No doubt about that. All right, let's do it. Thank you, Elena, for scribing. And we have Tansu in the teaching point seats today. Let's rock and roll.
Okay, so starting with the case. This is the case of a 66-year-old female who presented to the emergency department with sudden onset altered mental status for 1 day. And also, along with that, I would love to give you some of the HPI, which will include mainly her past admissions. So basically, 2 months ago, she had presented with 3 episodes of seizures. Her blood pressure at that time was elevated, and on examination, she was in post-ictal state and was moving all 4 limbs equally. Her GCS was E3, V2, M5 at that time, total equals to 10. CT head done elsewhere was normal. And according to the MRI that was done at that time, she was managed as a case of late subacute infarct. CSF analysis done at that time was normal, and she was also noticed to have a head tremor when her sensorium improved, which was probably thought to be a dystonic tremor. And so basically, she was diagnosed to be having a post-stroke seizure. So that is basically about her past admission. And now, from 1 day, she has been having like sudden onset confusion since yesterday. She's confused and not obeying to commands. So that's the first allegory.
Oh my gosh, it's so rich. Hui Ting, whenever there's so much information, you really have to try to slow down and approach it in a manner that is more digestible. So I'm just curious, what were you thinking? What would you be thinking if you had a patient with you who came in confused and you knew that yesterday they were normal? What kinds of things cross your mind in that kind of situation of acute altered mental status?
Yes, so the first thing that comes to my mind, of course, this is older patient. So I immediately think about the different possible differential diagnosis, bringing back to like the mnemonic, the missed mnemonic is very important to try to classify what bucket this patient is currently. I think about maybe metabolic causes because electrolyte disturbances in older patient is kind of expected in a way, and it could show a rapid onset of changing symptoms. So that would be something that I would think about, or maybe like infection causes, structural causes. It seems like this patient have a past medical history also like stroke. So neurological causes or trauma related is also in the back of my mind because the patient, when it's older, they are increased risk for falling as well, and that could lead to trauma and altered mental status, and also possibility toxic. In this case, more like polypharmacy. So I always remember with older patient, think about like polypharmacy because they have different comorbidity that may, Amo will teach us a little bit later. Maybe there's a medication interaction and can cause the altered mental status. So there are so many things going on now. And the first thing I would do is to try to stabilize the patient to see what is the most emergent symptom that the patient is seeing, and try to rule out all the emergency causes before I try to like, oh, let's try to get to the actual diagnosis. So I would just try to approach like more broadly.
I completely agree with you. I think that the missed mnemonic is a very helpful place to start for altered mental status, especially when it's acute in onset. And I love your filter of trying to think of the most morbid things and to prioritize polypharmacy or substances in older adults. I think if you take a step back and try to think of this not as a doctor, but as a human being in general concepts, and think, if somebody got this confused in one day, what's going to happen in 2 days, and 3 days, and 4 days? And so thinking about just how sick somebody got so quickly is really important, because if that line continues, then the patient will pass away very soon, right? That's why it's so important to pay attention to the time course of altered mental status. And most people who have a cause of altered mental status that you will find on the missed mnemonic, like hyponatremia or a urinary tract infection, or an expanding subdural, or a slowly accumulating toxin, usually present with days of symptoms. And so here you wonder, wow, so quickly. And so at the end of the day, there's one of two possibilities. Either she has a regular cause on mist, nothing unusual, but her brain is so weak from her prior problems that she manifests sooner, or she has a subset of the mist mnemonic that is more morbid and more rapid. And you might ask, should we call this acute altered mental status? Or should we call this hyperacute altered mental status? And I think if she was confused for 1 hour or 2 hours, you'd probably be very comfortable causing it hyperacute. One day starts to get at the gray zone. And it starts to be at the interface between hyperacute and acute. But because hyperacute is so much more morbid, I think that you probably would want to think about those causes, as you said, to stabilize the patient. So if you were to do the thinking in your head of what kinds of things cause somebody to get confused like this, snap, what would cross your mind in that situation?
I think the first thing I would think about is stroke.
Mm-hmm.
That is one of the first thing, and
Excellent.
that can change the patient. And it looks like this patient have subacute infarction.
Mm-hmm.
So I'm also wondering if this is the first time that this patient is presenting the symptom, or is something recurrent? Because I think we have seen in the past, for elderly patient, that they have a several trauma in the past,
Mm-hmm.
and they've been presenting the symptom very, very frequently, like intermittently, but it was not the first time presentation. So I'm curious to see, like, is
Mm-hmm.
this is the first time presenting the symptom, or is it something that has been ongoing?
Yeah, agreed. I think that whenever you're in the world of hyperacute altered mental status, I think immediately of the three S's. Is this a stroke, a seizure, or a substance? And it could be a substance deficiency, glucose, or a substance excess, opiates, as an example. The latter category, the substance, is the most immediately testable. You check a finger stick, and then you look for signs of opiate toxicity. That you can do that in 1 minute. That takes care of one S. It leaves the seizure and stroke hypothesis remaining if you don't find an answer. And in a patient who you're thinking about seizure or stroke, they are immediately, after they get an IV, sent for a rapid CT scan. And so in this situation in real life, if you were taking care of this patient, if you have a finger stick and don't have suspicion for opiate toxicity, the tension you will be feeling is, do I just get blood work and get an evaluation over the next hour, 2 hours, 3 hours? Or do I call a code stroke? I'm really curious just to pause here and ask all of you to share your thoughts in the chat or with yourself. With the information so far, assuming the glucose is normal and there is no signs of opiate toxicity, commit to your thoughts and let's discuss it as a group. Would you call a code stroke here? Or would you let the evaluation proceed in the normal manner with labs and imaging done over the course of hours? I'll give you a second just to think about that. Like, curious, Yuting, what's your instinct here? Would you think you would press the button for code stroke, or would you, is your sense that we have some time?
I will press the button.
Yeah, always press the button. I
And
agree.
I mean, I can be wrong, but I will just do the stroke code.
Yeah,
And
exactly.
if I'm wrong, that still means that I have more time. So I
Yeah,
have nothing to lose. So,
exactly.
mhm.
The reason to press the button is twofold. The first is that the patient got sick very quickly and you need an answer very quickly. She also has a history of stroke, so she could have another stroke. But here's the other practical reason. The only way to suspect a seizure in this situation, a seizure that would be either non-convulsive seizures or a seizure that has now being followed by the post-ictal state. The only way you will be able to think about that diagnosis is if you remove stroke from the picture. So if you're thinking about the three S's of hyperacute altered mental status, at the beginner level, you're beginning to remember them. Seizure, stroke, substance. At the level of a attending physician, what you're doing is you're thinking substance, stroke, seizure. Why? Because that's the order in which you can evaluate things efficiently unless you get an early clue. Substance, exam and glucose, stroke, CTA, and then seizure is more thoroughly entertained after those two things are occluded, specifically a non-convulsive seizure. You need an answer quickly, and if you wait hours to exclude a stroke, then potentially you're sitting on a bad stroke or you're sitting on non-convulsive seizures that you cannot even begin to entertain until you've efficiently ruled out stroke. So I think the nuance in this case is how sick she is, how so quickly. And for me, I know that mist may be what I activate eventually, but I'm still stuck on the three S's. Is she hypoglycemic? Does she have opiate toxicity? And if not, let's take a look to see if she had a stroke. If not, I would worry most about non-convulsive seizures. All right, Anmol, tell us more, please.
Amazing, amazing discussion. And moving over to the past medical history, she has the diabetes mellitus, hypertension, dyslipidemia, hypothyroidism, and obstructive sleep apnea. And regarding the medications, she's on metformin 500 mg, aspirin 150 mg, clopidogrel 75 mg, and atorvastatin 40 mg. She's also on thyroxine 50 micrograms, a calcium and vitamin D supplement, and tablet levetiracetam 750 mg. She has no known family history and there are no known allergies. The patient comes from a rural setting, that is from a village in India. She does not drink alcohol. She does not smoke. Her diet is vegetarian and there is no history of any recent travels. And there is no known animal exposure. Okay, so now moving over to the physical examination. At the time of presentation, her temperature, she was afebrile and blood pressure was 140 by 90. Heart rate was 88 beats per minute. Respiratory rate was 18 breaths per minute. And saturation was 98% on room air. The general appearance of the patient was that she was conscious, but not oriented to time, place, and person. HEENT was normal. There was no evidence of icterus. Pupils were normal, bilaterally equal in size and reacting. Cardiovascular, pulmonary, abdominal examination was normal. Regarding the neuro examination, her GCS was E4, V3, M5. That is equal to 12. She was aphasic, and there was the presence of mild right unilateral drift. No other neurologic deficits were appreciated, and her skin and extremity examination was normal as well. So this was about the second aliquot.
Thank you, Anmol. Hui Ting, what caught your eye with all the data that we got?
I'm kind of surprised that the patient is kind of fairly normal with, I mean, besides the neurological findings. So cardiac is normal, pulmonary is normal, everything that, like a secondary cause of autoimmune status, we try to like rule out. So for me now is my focus is more to the brain. So what happened there? What is the cause that this patient is having this autoimmune status or the changes, the abnormality that we see in the neurological exam. So I'm curious to find out a little bit more. And I'm also thinking of if this patient is taking the medication properly. All the list of medication that this patient, for example, thyroxine, if this patient is taken correctly or not. So if there is a wrong taking that, maybe that can cause also the autoimmune status. But yeah, I think my focus now is more about the brain, like what is going on inside that. So yeah, what do you think?
Yeah, I agree with you. It's amazing how much progress we can make to call this a brain predominant disease syndrome. And I think that the absence of cardiopulmonary abnormalities on exam reduces the probability of there being one at all. But in patients with brain issues, their ability to convey to you the issues that are going on is limited. So unfortunately, she's not confused enough to tell us that she's not having chest pain or trouble breathing or abdominal pain. So while a systemic disease has not risen to the surface, which makes it less likely, and focusing completely on the brain, a small door, I think, should be left open to the possibility that an EKG shows something and a troponin shows something, especially when we don't really know why she had a stroke and that she could have had a cardioembolic stroke, as Anmol has presented to us in the past on VMR. So I completely agree with you. All hands on deck to understand what's going on with her brain. And I'm curious, what did you make of her neuro exam? She has aphasia and a right-sided pronator drift. What thoughts crossed your mind with that?
Um, I'm thinking that if there's something like a very localized, any kind of lesion, because we haven't uh, talked about the possibility or maybe a mass
Mm-hmm.
that is in the brain that can be causing or even embolic stroke that can go to any of the territory. So that could be a possibility of the symptom that she's presenting currently.
Yeah, I agree with you. I think that the aphasia and the unilateral pronator drift being on the right side suggest a left-sided cerebral problem. That's not all we have. Most people with a left-sided cerebral problem are not confused. So I think it's important to say that we have to be careful that we are not confused because she may not be confused at all. And because of her aphasia, we are confused and don't understand her. So aphasia is a really, really important mimic of altered mental status and requires very astute observations to really try to figure out if the patient is in fact confused or not. And so you can try to navigate around that by using nonverbal communication to communicate with the patient, like handing her a pen or a fork or something to see if she would grab it and use it. So I think you'd have to be a little creative not to mistake this, because right now our problem representation is an acute encephalopathy with features of left cerebral problems, but it might just be that she's not confused. So at this point, I think we would have to say that either her entire cortex is involved, but she has disproportionate involvement in the left side, and the entire cortex is causing the confusion, and the disproportionate involvement of the left side is causing the aphasia and the pronator drift. Yeah, so it's intriguing now. It's also intriguing to know, is this her neurological exam that is developed as part of her sickness one day ago, or were these the permanent deficits that she had from her prior stroke? And all these things are actually very hard to tease out. And I think it would be a mistake to think that her exam now is new. It could be old. And it would be a mistake to localize this just to the left cortex. She's confused, and most patients with aphasia are not confused, but she may not be confused. We may be confused. There are a lot of different things to try to tease out, but definitely a concerning exam when somebody has diffuse encephalopathy with focality. You definitely, if you weren't inclined to press the code stroke button, I think seeing these deficits, you probably would be closer and closer to pressing it.
So, Rabih, a question. In real time, at this point, if we see the patient with this clinical presentation, what will be the next step for you? You will be asking for like what type of labs or imaging? What is the thing that you concern the most, and what
Yeah.
the management will be?
I go into my code stroke protocol, which is history, medication, vitals, and lab. And I need to fill each of those things with one category before I press the code stroke button. So history, meds, vital, lab. What history? What her last known normal was. One day. Medications, anticoagulants, and antiplatelets. Aspirin, Plavix. Vital sign, blood pressure. Lab, glucose. And after I get all that data, code stroke. And what would happen is she would get rapid IV access, rapid blood evaluation, and she would go straight to the CT scan for a CT with contrast to look for any large vessel strokes. And neurology would be assisting with that. And if that were negative, she would then immediately go for an MRI to see if she has a stroke before I see her again, because nothing I can do is of value enough. So before you call a code stroke, you need to have one piece of history, one med review, one vital sign, and one lab. Last known normal, antiplatelet or anticoagulants. Vital sign is the blood pressure and the glucose. And that's what I'll be doing in real time. And Nara's barking now. I don't think he likes that answer, but we'll see if Anmol agrees.
Thank you so much for the amazing discussion. And moving over to the labs, HP was 11.7, MCV was 79.2, WBC was 12,260, and they reached 21,000 during the course of the hospital. Predominantly neutrophils, 78% were there. And platelets were 306,000. Regarding her electrolytes, sodium was 137, potassium was 3.99, and RBS was 148. Total cholesterol was 158. Total serum bilirubin 0.66, and AST 30, ALT 16, GGT 18, and total serum protein was 7.1. Serum albumin was 3.7 and globulin 3.4. BUN and creatinine were normal, and serum uric acid was normal as well. T3 was low at 47.1. T4 was 5.67. TSH was increased at 4.84. Viral markers were done, HIV, Hep B, Hep C. The patient was non-reactive. And in the HPI, I mentioned about the past admission 2 months ago. There we did not clearly mention about the imaging. So now we do have the imaging. And regarding the MRI, which was done at that time, it showed a left frontal lesion. that was T1 hypointense, T2 isointense, with diffusion high intensity, diffusion weighted imaging, and no hypoattenuation on ADC with diaryform enhancement. This was the result of MRI 2 months ago, and MR spectroscopy was also done 2 months ago, which had shown a lactate peak. That's about the Saliquot.
Wei Ting, are you an MRI expert? Because I'm not, and I have no idea how to interpret this MRI in detail. So maybe we can talk about that at the end.
Yeah,
What
I
struck
agree.
you with the labs?
I agree. Yeah, so one of the things that I've seen, there's the white blood cell. I was expecting an infection. It looks like there's an increase in white blood cells, predominantly neutrophils. So I'm wondering, where is this infection coming from? Maybe a urinary tract infection. And the patient is, I mean, it's not it doesn't have fever, doesn't have all the symptoms, but it looks like they have an elevated neutrophil count. The platelet, if let's see, it's not 6,000. I think
Yeah,
it's a
it was
6,000.
normal.
It was normal.
Yeah.
Okay, so that is one of the things that I was looking at, and yeah, and of course I'm looking forward to try to discuss about the MRI lesion, because I think that's one of the most important thing here, and also I think the T3, the thyroid function test is also a little bit abnormal, and that could also be part of the reason why this patient has autoimmune status. But I think it's between the infection and what is going on with the MRI at this point.
Yeah, I completely agree with you. I think the MRI is very, very concerning, but we were surprised, right? Initially, we said there's no evidence of a systemic disease. And now look how our thoughts have changed, where you're emphasizing the possibility of an infection. And it just goes to show you that when somebody's confused, you just have to get more and more data to really understand what's going on in their whole body. And a white count of 12,000 may be something you can ignore, but a white count of 21,000 is much harder to ignore. And so now our problem representation becomes a systemic inflammatory response to a predominantly brain disease. And so we'll have to inventory all the places that somebody can have systemic inflammation, like the lungs, like the blood vessels with blood cultures and chest imaging, but also abdominal labs, which are unrevealing so far, and urinary labs. So now, instead of just focusing on the brain, we have to focus on the systemic aspect. But I agree with you, the brain is very, very concerning, and it's much more likely that we're dealing with a systemic disease that involves the brain in a very serious way. I think the MRI is hard to I think all we can really say with confidence on the MRI as non-experts is she has a brain lesion. So if we just talk about that in the simplistic way, what do you think of as causes of a brain lesion in general? If you have no more information, just say, oh, look, there's something there. What would cross your mind as possibilities?
Actually, this patient, I think about the possibility that that we see now, these are chronic lesions. That is not something new that is happening, it's something old that is already there, or the possibility of the new mass, or the possibility of embolus. Those are the lesions that come to my mind if I say, oh, this is something new, maybe it's an embolus because the patient is taking anticoagulant, or maybe it's a ischemic lesion. So yeah, that's my thought.
Yeah, I think that a mass anywhere immediately makes us worry about cancer immediately. So we have to think about that possibility for sure. A mass anywhere also can make us think about an abscess, a contained area of pus. And whenever you see a mass in the brain, those are your two first considerations. But the brain is very special. When the brain is damaged by whatever process, be it ischemia or trauma, it heals not by fibrosis. Every other part of your body heals with a fibrotic reaction, like scar formation. But the brain does not have the ability to fibrose. It heals by liquefactive necrosis. A great timing, Maddie. Thank you. It just popped up on my screen. Um, and so it causes a hole in the brain that looks like a mass. That's why the differential diagnosis of a brain mass is cancer, infection, and rarely autoimmune, but also things that cause necrosis, be it ischemia, like Anmol said, a subacute infarct, or trauma. Boom, left frontal lobe, prior seizure from epilepsy, hypothetically. Boom, left side, massive trauma, liquefactive necrosis. Or radiation necrosis. So I think of brain masses in two different categories. Is there an inflammatory process going on, cancer, infection, the predominant, followed by autoimmune disease? Or is there actually an inherently necrotic process absent inflammation from hypoperfusion or from trauma? And I think here we have to proceed knowing that both are possible. But as you said, the neutrophilia and the leukocytosis should make us prioritize first an infection or a cancer. And the very first step is to try to figure out, is it just the brain that's involved? Or is there an extracranial signature of this disease process? And that begins by recognizing where do things usually spread to the brain from? And there's two answers: lungs and cardiovascular system. So we really, really need to know, in order to understand what's happening here, whether it is, as you said early, an isolated brain problem or a brain problem featuring cardiopulmonary disease. And a high quality imaging of the chest and a high quality assessment of the heart to answer the question, isolated brain versus brain plus systemic, will really, really help us make progress. So that's where I'm at. I'm curious what thoughts or questions you have to add, Huiting.
Yeah, I mean, yeah, I totally agree with you, and I like what the chat is like. The chat is on fire, and I like what Maddie just wrote down, like look down from the brain, as you mentioned, because if something is going on in the brain, and now we're seeing some signature, like systemic signature, we have to think about maybe it's not the brain, maybe somewhere else. Then now we have to do like chest X-ray or other imaging. And I'm just curious to see if this is like an endemic infection that we don't know, because taking a step back to the past medical history of the patient, the social history, Amo, I mentioned that she lived in rural India. So this patient could be exposed to different type of parasite or fungal infection that we don't know about. And now I'm questioning if this patient is already previously immunocompromised patient. And now maybe they having like TB is something like it's incredible that everything maybe back to TB. Every- or
100%.
maybe a cryptococcus meningitis could be a possibility, or some kind of parasite. So I'm just curious to see if this is actually becoming more infectious cause or it's just like neurological. But I don't know, maybe now we have to like shift back a little bit our attention to more infection etiology to try to understand the process of this presentation.
Very well said. I couldn't agree more. I'm right there with you. Alrighty, Anmol. What do you have next for us?
Okay. So before I go ahead, do you want to know any other labs? Because from my side, I have completed the labs. And if you need anything else, I can
No.
share.
Yeah, I think honestly, I think we probably if we could get whatever data we want, I would probably want to understand lung status and heart status, which are both evaluated not necessarily by labs, but chest X-ray, CT scan, EKG, echo, those kinds of things, and blood cultures. I think that would be most illuminating, but you're the boss, wherever you want to go.
Okay. So definitely this patient's urinalysis had 90 to 100 WBCs. And I'll tell you how it was done. So this patient a scan had to be done. So we have the brain MRI, and I will share the screen for that. Give me
Thank you, Anmol. Wow, this is awesome. Ooh. Mhm. Oy, oy, oy. Yeah. Wow. Okay.
So let me know if you want me to stop somewhere or it's
Yeah, maybe. Yeah, I think anywhere that's showing, honestly, I'll just share my thoughts because I think I'll just share some general principles, honestly, then pass the mic to you. I'm not an expert radiologist, but I think in general, you want to understand, you want to make sure that you're not distracted by the large mass, and to make sure that you inventory the rest of the brain for any subtle clues. And I didn't see any masses anywhere else. And then what you want to do with the mass is you want to understand three things about it that are real anatomic. First is, are there any consequences to the surrounding tissue? I.e., is there edema? Then you want to understand, is the mass at its margins at the wall? Is there enhancement or contrast enhancement at the wall? And then inside, you want to understand is if there's diffusion restriction. So when you're trying to understand a mass, what's happening outside? Is there edema on the adjacent structures? Is there compressive effect? Here, the answer is yes. You can see there's midline shift and there's a lot of edema around it. The part that I don't know how to interpret on an MRI, having received no training, is if there's contrast enhancement of the wall. And then finally, is there diffusion restriction inside? Those are the three most helpful variables. So I don't know, Anmol, if you have that information, or if folks in the chat are able to read an MRI. But I think that's probably the most helpful three things to know about the mass. Yeah, what are you able to share about the radiology?
Um, okay, so basically, to be very honest, this when I actually joined CP Solvers, just a side of the case, you guys always discuss radiology, and when I came across this case, I went to actually see what the CT, like what MRI showed, and
Yeah.
I was just astounded to see, like, wow, I mean, this lesion, and I was just because of this imaging, I really wanted to present this case because I was
Yeah.
amazed by that. And so the brain MRI showed acute hematoma in left frontal lobe involving the cortex, subcortical white matter, corona radiata, with adjacent edema causing a mass effect, midline shift of 8 mm towards the right side. And the hematoma basically measured 5 by 4 centimeter. And about the and she also had discrete hyperintensities on T2 or flare without showing diffusion restriction, and seen in the subcortical and periventricular white matter involving bilateral cerebral hemispheres. Then ventricular system, bilateral sylvian fissures, cortical sulcal CSF spaces, and basal cisterns, they are prominent. suggestive of chronic ischemic changes with age-related cerebral atrophy. And plain head CT was also done, which was suggestive of, again, a left frontal bleed with perilesional edema and mass effect. That was regarding the brain imaging as a whole. Now, I would love to know, what do you think about this case?
Yeah, what do you think, Yu-Ting?
Oh my God, what I'm thinking is I have to learn a lot. Oh my, there's a lot of information about the MRI. So yeah, I think this patient basically has this acute hematoma. So I'm wondering if the mass is like a consolidation of all the trauma itself. It's like hemorrhage in there. So I don't know. There's a lot of information. I think I need your help to interpret this.
Yeah. Yeah, no, for sure. It's actually a very, very complicated situation. And forgive me for those of you on YouTube, but I'm gonna pause the recording just to show a schema. If you're interested in seeing these schemas, you can check them out on RLR CP Solvers, or you can come hang out with us live. For me, I think this case is showing us the principle of a brain mass having a broader DDX than masses everywhere beyond just infections, cancer, and autoimmune disease, and illustrating the principle that you can have trauma-induced masses and primary vascular issues. So my next steps would be to get a very thorough trauma review history, and also review her prior imaging if possible, to see if there's any evidence of trauma to the head. If not, I think the possibility of a spontaneous intracranial hemorrhage is important, of which a hemorrhagic conversion of a prior stroke is probably the most likely. But then you saw in that schema, there's a whole set of things of rare causes that we would entertain only afterwards. So that's where I'm at. I'm curious where your thoughts are.
Yeah, I think I'm right there with you. I'm just really intrigued to know more about the real cause of this mass, because at this point we are just still debating, okay, this is something systemic, something that is caused by multiple trauma. What is it going on? So I think the real thing happening here is to just going back to what's happening with the patient, instead of just focusing at the current presentation, to just look back what have been going on with this patient, how has been the evolution of her symptoms along the way, and now to try to understand a little bit more the current presentation, because sometimes we just so focused on what's going on now, but we don't know what led to this point of the presentation. So yes, I'm curious, like you, to go back and see what is going on with this patient, and what led to this point, of her symptoms. Yeah. So I'm very intrigued to see what is the final diagnosis.
Mo plays her cards very well. I completely agree with you. Yeah, I think you have to go back in time to see what happened. Either go back to the imaging to see she had a stroke there that bled, or go back to the patient to see if she had a fall. Going backwards in time, I think, is a wiser investment, but I'm cautious. Her neutrophilia might be giving us a clue that she has some systemic issue going on. So if we go back in time and we don't find an answer, we might have to refocus on the neutrophilia in real life. All right, Anmol, tell us what you found.
Amazing discussion again. So for this patient, neurosurgery was consulted, and left frontal craniotomy with space-occupying lesion and hematoma removal was done. A brain biopsy was done in view of space-occupying lesion with bleeding, and on microscopic examination was seen brain parenchyma exhibiting a cellular tumor composed of cells arranged in diffuse sheets in a fibrillary background. The cells had moderate cytoplasm, ovoid nuclei, granular chromatin, and inconspicuous nucleoli. there was increased mitotic activity, areas of necrosis were seen, and microvascular proliferation was seen. The microscopic examination was in favor of a specific diagnosis. So what do you think about it?
Thank you, Anmol. Vitang, what do you think about this data collection that you just got?
So I think it could look like a mass, a tumor, a malignancy that we didn't really invest our time in malignancy, but it looks like this patient could be presenting sort of brain malignancy, and one of the most common that it come to my mind is glioblastoma. But I have to think about a little bit more what is the characteristic of what is the presentation of patient. But I think we are leading to this patient having malignancy, and that will explain a lot of all the symptoms, all the inflammatory process that this patient is having.
Yeah, I think it's such a powerful story, and a very, very humbling story about not necessarily an ischemic stroke with hemorrhagic conversion, but a mass with hemorrhagic conversion. And I think that underlying mass was probably camouflaged by its bleeding propensity. And so this case becomes understanding why this patient has presumably a primary brain mass. And you're right, the most common cause of a malignant brain mass is a glioblastoma multiforme. The other important one to think about in older adults is a primary CNS lymphoma, of which after those two things, there are a lot of rare causes. I think that's what I would be most worried about, is a primary malignant brain mass. It's much less common to have a primary malignant brain mass than it is to have a systemic metastatic mass. But I think it would be very unusual to make this much tumor in one spot and not have other foci of metastatic disease. So like you, I am in the primary malignant masses, and my DDX is based on base rate GBM or primary CNS lymphoma. I actually don't have any sense of I don't have any knowledge about the histopathology of these conditions. So I would be very grateful for the pathologist to tell us what the answer is. I wouldn't be able to tell you, but I'm struck by how aggressive this is. It has increased mitotic activity. There is necrosis and microvascular proliferation. So that really signals to us that this is not something benign, but rather a malignant tumor. Anmol, enlighten us, please.
So this patient was diagnosed as a case of glioblastoma multiforme, WHO grade 4. And so as I said, the neurosurgery consult was taken and the left frontal craniotomy was done. After that, the patient had a good recovery of sensorium with no deficits. And so basically, so her immunohistochemistry results, they are awaited, and after which the patient would be decided to be started on chemo or radiation and everything. So regarding glioblastoma multiforme, what I read was that it is referred to as grade 4 astrocytoma. That is a tumor that arises from astrocytes, and it is the most common primary brain tumor in adults, and the most common ages in which it is diagnosed is 60 to 70 years, which as we see in this patient. And it usually has a very bad prognosis with a median survival of around 15 months. And basically, symptoms may vary according to the location of the lesion, but they are usually non-specific neurologic symptoms like headache and seizures. And we label this patient, the pathologist labeled this patient as grade 4 because of the microvascular proliferation and the areas of necrosis which were seen. And regarding its treatment, what I have heard is that surgery is the mainstay of the treatment. But the tumor cells, they basically infiltrate the surrounding brain tissue as well, for which we need chemotherapy and radiation therapy after that. So that's what I learned from the case, what my takeaway was. Yeah, thank you so much.
Emil, this was so well presented. I mean, the way you got us to like really, really power and struggle through the diagnostic journey reflective of what happened is really, really cool. And I'm humbled by how bleeding can distract from the core issue and that really thinking about either an underlying stroke or an underlying tumor is really, really important. And I think this patient um, got this patient suffered from the fact that she had midline shift, but I think that forced people to really pursue a brain biopsy. I can easily see if she didn't have a midline shift that people would just be like, oh, let's wait to see what happens. So in some ways, her severity pushed for a biopsy, which was crucial and very, very informative. It also just showed me how much we depend on radiologists because there's so much we can do, and all we can really do is just to be like, oh, this is just a brain issue, there's no systemic issue going on. And you really need those expert eyes to be like, actually, no, this is not a subacute stroke like the first radiologist said, this is actually a tumor. um I'm humbled by that. I'm curious what your reflections are, Fitting, of this really, really interesting case.
Yeah, I think first of all, Amo, well done presentation as always. And I learned a lot. I think we started with something as common as altered mental status, and we tried to deploy the whole schema, thinking about the different possibility. And in the end, it turns out to be a malignancy that it was like it just there's a lot of like the condensation of the symptoms that we have from AMO. I think I have to read a little bit more about glioblastoma. And actually, in my lab, there is a team that work in glioblastoma. So we're targeting, we're trying to figure out like targeting therapy to that. So yeah, it's really interesting to do the discussion and to come up with the diagnosis, and then later on to read more about what is gonna be the proper management. So I think I've really, really learned a lot from this case, and I learned so much from the people from the chat. They were putting so many information, and yeah, I think yeah, thank you so much, Amo, for your for this case, and thank you, Rabih, for teaching me along the way, as always.
Thank you both. It's such an honor to be in this conversation with you both on a really, really enlightening case. I'm so glad that radiology caught your eye and you brought the learning to us. And you take, I thought you discussed it so well, including, of course, the joy of mentioning and suspecting the diagnosis right before the relief. So congrats to you. All right, Tansu, take us home. Oh, go ahead, Anmol, please.
Thank you for that. And I actually just wanted to mention that we've been in my hospital, like as a junior resident, I'm posted in like particular wards. I think they call it floors in USA. So we're responsible for all the patients which are like who are like there on the floor. So when I actually came across this patient, she had a long course, like another course in the hospital. I was about to make the discharge summary for the patient. I was like glioblastoma multiforme. So I was like, oh, how was she diagnosed? I went
Wow.
all of the admissions, like what happened, what was done, what was the imaging. So that's how I actually learned about it.
Amazing. I mean, that's just a marker of the hungry and astute learner that you are to recognize a very educational case and to share it with us. I think most people would have just written the discharge summary and left, but so kudos to you, Anmol. That's very, very cool. Thank you. All right, Tansu, take us home, please.
Thank you so much, Amo. What a masterful presentation of this case. And Huiting, you did great. I'm so overjoyed to be surrounded by such smart people like you all. So we started with a 66-year-old patient who had altered mental status. And when we talk about acute AMS, we always think about our NMIST framework. And here, attention to the time course of AMS is so important because some causes of AMS presents more hyperacutely or acutely than the others. And onset of one day is kind of the gray zone in between hyperacute and acute time course. And most causes manifest in days and not hyperacutely. So given the patient's extensive past medical history and medications, we have to think here, either the patient had a chronic problem with acute decompensation right now, And we should ask about any history of similar events to elucidate that. And or the patient has an acute event. And when we talk about the acute, hyperacute events in altered mental status, we think about our 3S's: stroke, seizure, and substance. And for substance, there can be either deficiency or excess. And in AMS, management is more important than diagnosis at the first look. And so the order in which to evaluate things efficiently is substance, stroke, seizure, because substance, it's testable ASAP with a point of care glucose, and opioid overdose is easily reversible with naloxone. And then we can go on to evaluate stroke, and we can then go on to evaluate seizure. And all of this depends on the patient's pretest probability of substance, stroke, and seizure problems as well. And in a patient with brain issue, we shouldn't forget that the patients have limited ability to convey other issues, so they may not rise to the surface immediately. In this patient, we found out that there was aphasia and right pronator drift. And when there's aphasia, when a patient is experiencing aphasia, we shouldn't forget that this is a mimic of altered mental status, and we should try to utilize nonverbal communication for assessment, because we might mistakenly accept this as altered mental status. And whenever a patient has diffuse encephalopathy and focality, this lowers our threshold for code stroke. And in order to alert the code stroke, we look at patient's history and we ask what was the last known normal, review the medications, especially for anticoagulants and antiplatelets. We check the vitals. Here, blood pressure is important. And in the labs, we should check glucose ASAP. And then we can alert code stroke if our suspicion is high. And when we activate the code stroke, we should get a rapid IV access, get a CT with contrast to evaluate for large vessel stroke. And then if that's negative, we get an MRI. In the labs of this patient, we found out that she had leukocytosis. So we started thinking, is this systemic inflammatory response to a brain disease or disease elsewhere? And so we started looking for extracranial signature of a systemic disease elsewhere. And here, one of the most important considerations is the cardiopulmonary aperture, because diseases usually spread to brain from the heart or the lungs. And the brain mass differential diagnosis includes cancer and infection most commonly. And then there are other causes like autoimmune, trauma, radiation. And we shouldn't forget that brain does not heal by fibrosis, but by liquefactive necrosis, which can resemble a mass. And then while evaluating brain mass in MRI, we look at 3 components. Those are the presence of edema, contrast enhancement of the walls, and diffusion restriction to the middle of the mass. And then in the hemorrhagic brain mass, DDX, 2 prominent causes rise to the surface. These are trauma and vascular causes. And for that, we should evaluate past imaging for scalp or bone changes. And then for spontaneous intraparenchymal hemorrhage, there are 3 causes that we should pay extra attention to. First of all, hypertension. Hypertension usually causes deeper bleed. That's the more common way of presentation for hypertension. And cerebral amyloid angiopathy that causes microbleeds everywhere, usually. And then the third one is anticoagulant use. In this patient's case, the biopsy features of increased mitotic activity and microvascular proliferation raise the suspicion for a malignant brain mass. And then when we think about primary malignant brain masses, the base rate says glioblastoma, primary CNS lymphoma are the 2 most common. And then there are some rare causes. In this patient case, the final diagnosis turned out to be GBM. That's all from my end. Thank you so much.
Oh my gosh, Sean. So I don't know if you're watching, you're probably looking at the screen. I don't know if you're watching people's head. This is the vibe to your teaching point. It's like, and I think Shreyas was embodying is the I vibe with your teaching points head nod the whole time. That was amazing. That was really, really cool. Such a brilliant walkthrough. I think you captured all the teaching points in the case very, very well. All right, y'all have a great rest of your day, and hope to see you tomorrow for RLR. Bye.